I'm very excited to be here today to show you the other side of the story. Question for the audience: how many of you have ever been to Alabama? Raise of hands. Wow, more than I would have thought. Excellent. Well, I'm from Birmingham, which is right there in the center of the Deep South. Now, that was the best map that I could find of the Deep South. However, I might argue with a few of those states. North Carolina, Virginia, probably not really the Deep South. I'm from the core of the Deep South, the Republican majority, of course. So a couple of disclosures that I do have, not related to CME, that probably make me an interesting person for this particular talk with this particular group. These are things that I would not typically share in Alabama. The first thing is that I am a progressive. Note that I did not use the word Democrat. The reason is Democrats are extinct in the state of Alabama. Truly, the Democratic Party does not exist anymore in the state of Alabama. We do have a few Democrats on the ballot who have actually won in a few locations in Alabama, but the party itself does not exist. The other thing that I would like to disclose is that I am actually gay. How many of you know a gay person from Alabama? Okay, now you do. So I just wanted to share those things to tell you that it's always nice for me to get out of my area of the country and kind of, explore other ideas because I don't necessarily get exposed to those on my day-to-day experiences. So, stereotypes. Obviously, I break the mold here. This is my first time to Oregon. I have been out west before, but I've never actually been to Oregon before. Most of my exposure to Oregon has been through college football, which, as you can imagine, is very popular where I come from. So stereotypes that I've had of Oregonians has been kind of wild and crazy, wanting to try new things, innovative, outdoorsy. And I would say that that's pretty accurate based on my experience here in the last few hours. Curious to know your stereotypes about Alabamians. Anybody wish to share? Roll Tide, that's right. So, in general, I think the perception across the U.S. is that we tend to be more conservative. That would be pretty accurate. We're not as healthy. That would also be pretty accurate. Tend to be more focused on religious beliefs and family beliefs, and I think that would be pretty accurate as well. I think, I'm not an anthropologist, but one thing that I would say generally is that people in this area of the country, as well as those in the Northeast, tend to be more future-focused, whereas us in the Deep South tend to be more focused on the past. And it is that difference between our cultures that I think has led to a lot of the decisions that we have seen, particularly with regard to the Affordable Care Act. There is a lot of mistrust of government in my area of the country, and in fact, we do not use the term Affordable Care Act. It is indeed Obamacare, and it is blamed for literally everything. If your garbage doesn't get picked up on a particular day of the week, it's because of Obamacare. If you can't get in with a physician, it's definitely because of Obamacare, okay? So this is the reality that I come from, and yet, as a progressive living in my state, I'm trying to do whatever things that I can to move things forward. So I want to talk a little broadly about the health in the Deep South, particularly contrasting that with the state of Oregon. I like to focus on what I call the 5 modifiable risk factors of poor health. Which are basically the things that you can impact through your own behavior, whether it's by choosing not to do these things or by controlling these particular disease processes. So as you can see, for tobacco use, a difference there, probably statistically significant between Oregon and Alabama. That is specific for cigarettes. If you add in marijuana, it would be interesting to see what those statistics would be. For diabetes and prediabetes, Alabama actually has the highest rate of diagnosed diabetics in the United States. And you may not be aware, or you may be aware, that 1 in 4 diabetics in the U.S. is not aware that they have diabetes. And I suspect that a large majority of those reside in the Deep South. So it is highly likely that that percentage is even higher than what is reflected there. Also not surprising, high blood pressure, high cholesterol, we excel. Some of that probably has to do with genes, a lot of it has to do with obesity and, of course, dietary impact. So, differences, yes, although I have to say, if you take a step back and kind of look at those percentages next to each other, we really all have the same problems, you know? It's just a very mild degree of difference overall. But if you look at the performance of health systems, this is from the Commonwealth Fund study that looked back over 5 years, 42 different indicators that included cost, access to care, quality, and you can see the Deep South is quite dark there and is not doing very well. Well, can we blame all of that on our dietary habits and our family history and our obesity? Probably not. Probably a lot of it has to do with the structure of our health system. But Obamacare was supposed to help that, right? Well, I love this picture. So, difference between poverty in Oregon, you have micro houses, right? I love that concept. And then in Alabama, we of course have trailer parks. There are really significant differences between income and probably significant differences in cost of living as well that can't be overlooked. But the Deep South is in red. We are at the bottom in terms of median income for our population. Connecticut and Massachusetts are highlighted up there in blue, and then Oregon's right there in the center. So Alabama itself, the median income in 2013 was about $43,000. Now, Alabama was one of many states that made the decision not to expand Medicaid. We have a governor who is a dermatologist, physician. He's very, very, very conservative. There has been some hope that he would see the light as a physician and would eventually expand Medicaid in our state. Unfortunately, he has lost a lot of political credibility lately. His wife of 50 years is choosing to divorce him because he had an affair with his communications specialist. So I think any hope that we had of expanding Medicaid in the state of Alabama anytime soon is probably past. So we're faced with a very dim reality. Medicaid in Alabama is one of the worst funded in the entire country. Our Medicaid recipients are limited to 14 physician visits a year, period. Regardless of how many problems you have, regardless of how many specialists you need to see, you only get 14 visits. You burn them up, that's it. For hospitalization, you get 16 days, period. If you go above and beyond that, you get charged for it. Brand name drugs, think about people who need to be on antipsychotics. A lot of times we don't necessarily have generic drugs available. You get 5, that's it. 5 a month. 5 drugs, brand name drugs. So very, very, very sharp limitations in the benefit. And this shows you, with Alabama choosing not to expand Medicaid, if you think about where our median income is, if I can get it to show up, it would fall about right there, okay? So anyone below that area, which is half of our population, you see a majority of that would be people who we would hope to be covered by Medicaid. But in actuality, children we do pretty well. Parents, we're down here. $3,829 a month. You have to earn less than that to be eligible for Medicaid. If you're a childless adult, sorry, you're out of luck. Nothing at all, okay? So we have a lot of people in the coverage gap, but we're not alone. The deep red indicates states whose Medicaid eligibility levels are an income of less than $5,000 a month. You see that is mostly states in the Deep South with a few. Yeah, it's pretty shocking. I was pretty shocked to see this. So we have a lot of people, particularly obviously in those states without Medicaid expansion, who really are struggling, and we as physicians are faced with a dilemma ethically of, how do we get people the care that we know they need, but yet they can't pay for, and our state won't agree to move forward to give them access. Not surprisingly, of those who fall in the coverage gap in the U.S., 89% are in the South. So Obamacare hasn't necessarily impacted us the same way that it has impacted you guys. Like I said, it's blamed for a lot of things, but we haven't seen a lot of good come out of it, mostly because of our own decisions, quite frankly. So on a different front, we do have a lot of people who are working. Of firms that offer coverage to their workers, we do pretty well. We have the darker colors indicate these are firms that offer any health care plan to their employees, okay? Exhibit 8 down here shows workers who are eligible to receive that employer-sponsored coverage. Those who are full-time, work enough hours to be able to be eligible. That's a lot of folks in the South, darker color, that's good. But interestingly, employer-sponsored insurance take-up rate, those who actually accept the employer-sponsored insurance, kind of low there. Interesting. Well, one of the reasons why is because a lot of the financial burden of those insurance policies that employees are eligible for falls to those employees. They typically, of course, in our state, we have lower wage earners, but they're paying a higher percentage of the premiums. So if you're making $25,000 a year and you have a choice of buying a family plan that's $12,675 a year, or paying a penalty to the federal government for not having coverage, what are you going to do? Pretty obvious, probably, right? The economic choice would be go without. And so that's what we're faced with. A lot of patients I see are employed and eligible, but don't accept their employer-sponsored insurance. So at the Baptist Health System, which is where I work, we're a faith-based, not-for-profit, smaller health system. We have 4 hospitals in central Alabama. And we have about 50% of our patients who are Medicare recipients, either Medicare or Medicare Advantage. So we are very well aware that we have to move towards value-based care and population health management. So in order to try to make sure that patients who are engaged with us at a younger age are not so ill when we are responsible for them in the Medicare age, we had to come up with an approach for engagement with patients who are still employed, may or may not have insurance. So what I've been working on the last year and a half is a new service line which bridges employer-based wellness programs, which many of our employers in the state have, with access to primary care and population health management. Were you aware that Alabama, at least on the commercial side, is basically a single-payer state? We have the least competitive insurance market in the country. Blue Cross Blue Shield of Alabama has 95% market share in the state of Alabama. Incredible, right? Yeah, I know, this is totally not your reality here in Oregon. Blue Cross Blue Shield of Alabama has become very efficient at claims processing, very good at rate negotiation. They have a PPO plan, and basically, if you're a provider in the state of Alabama, period, you're going to accept Blue Cross Blue Shield's rates because you don't really have an option otherwise. Blue Cross Blue Shield of Alabama typically pays less than Medicare. Yeah. Some of the procedures they pay a little bit more, but primary care, their rate is less than Medicare. So you can imagine that can be very devastating, and oftentimes physicians who are trained in other states but may have connections to Alabama choose not to come back for that very reason. It's very difficult to make a living. So Blue Cross Blue Shield of Alabama, with their 95% of the commercial insurance market, interestingly enough, 70% of their book of business is claims administrator. So they're not really all that familiar with managing risk, and they haven't invested in the infrastructure to manage risk. We actually have seen that with some of the federal plans on the exchange. Blue Cross Blue Shield admitted when they were posting their rates for this coming year that their medical loss ratio for the plans on the federal exchange for which they are at risk for those patients is greater than 100%. They're losing money. So they don't know how to do it. So what we at the Baptist Health System are trying to do is take their clients, these large and medium-sized employers who are self-funded, and give them the infrastructure for population health management and management of risk, which we ourselves are learning to do through several Medicare Advantage risk-sharing arrangements, as well as a Medicare Shared Savings Program that we have. So our Be Well initiative starts with workforce health screenings. Most employers who are medium and large size offer something like this. Basically, it's a yearly screening where all the employees come in, they have their BMI measured, their waist circumference, they have a finger stick blood glucose and cholesterol check. And we do these workplace health screenings and not only give each individual participant information about their risk factors, but we also give the employer a report built around those 5 modifiable risk factors for poor health. And with that report, we are able to discuss with that employer the areas where they might want to focus their workforce wellness efforts. Now, also what we do is we offer stages of change. In addition to getting the data with regards to the biometric screenings, the lab work, et cetera, we also assess every individual's stage of change. So, if somebody is not willing to consider quitting smoking, then you don't necessarily want to put the same intervention efforts towards those individuals as you would someone who's actively quitting or planning to quit. So that's part of our assessment as well that we present to the employer. So, as I said, we take that group health profile and then layer on top of that our 5 risk factors programs. We do on-site diabetes education as well as pre-diabetes diabetes prevention program planning. We do intensive tobacco treatment programs. We also are collaborating with some local universities, Samford University, which is a Baptist private college in the Birmingham area, to provide some on-site medication management services as well. Again, directly with the employer, because Blue Cross Blue Shield very, very frequently in their plan design does not include these services, okay? We also have a telemedicine platform that we are using in a variety of settings, and as you probably are not aware, Alabama used to, until last month, had the most restrictive telemedicine regulations in the country. Texas then beat us out. And then, due to threat of a lawsuit, Alabama threw out all of their telemedicine rules. So we currently are the Wild West again. But we still had to find a method of having these telemedicine visits paid for. And so, in essence, what we're doing is working with the self-funded plans. All they have to do is tell Blue Cross to flip the switch. And if that claim comes across, we get a parity payment. So we've done that with our own health system, and we're also doing that with several other large employers in our region. We want to increase access, and we're trying to utilize the resources that employers have on site. Some of these have nurses, some have nurse practitioners, and so we're expanding their ability to take care of individuals on the work site by providing collaboration with nurse practitioners, or providing additional physician oversight for the RNs to allow them to actually treat the patient in addition to assessing the patient with a physician order via a telehealth visit, for example. And then lastly, we're bringing primary care to employer sites that might not otherwise invest in an on-site clinic. Maybe these are employers who don't quite have a large enough population to make that investment. Well, we have bought a RV outfitted as a primary care clinic. I know that y'all have some RVs that do healthcare things in the Portland area. I saw one last night on Pioneer Square doing some eye exams. But this one is specific for primary care. It is truly a mobile doctor's office, 2 exam rooms on board, and we go to employers' work sites on a rotating schedule, providing routine follow-up visits for people who are hypertensive, diabetics, et cetera, and also providing preventive care to individuals who might otherwise choose not to obtain that care. And then when we're not on site, we offer the telehealth visits for acute issues that may come up. These are just some more pictures of how we're expanding with the nurse practitioners to provide treatment in addition to the assessments that they're able to do. And then this is a photo of one of our telehealth kiosks at our, actually at the Baptist facility. We're using it with our own employees. And interestingly enough, so I'm the telehealth provider right now, the only one. And about 50% of the patients that I have seen via telemedicine, I have not been able to actually complete their treatment via telemedicine. One of the most valuable things that I have been able to do is to pick up the phone and call their primary care physician if they have one, get them in with a primary care physician if they don't, get them into a specialist if that's necessary, and do it same day. 100% of the time, I've been able to get those patients in same day. And that has been invaluable, not only for patient satisfaction, but also for our workforce in making sure that people are at work and not having to leave for excessive periods of time for doctor's appointments. And then here are pictures of the bus that we have coming I'm super excited about. So it's a little different than what you guys have been doing here. Certainly we're making baby steps compared to other areas of the country, but we're trying to do the best we can with what we've got. And I look forward to making further steps in the future. So thank you very much for listening, and I'm happy to take questions. No questions? All right.
No questions? I have one. Would you like to ask a question? Go ahead first. You're real.
I am Jacqueline. Welcome through. I was a former Intel employee who works extensively with our on-site care.
Yes.
I have a couple questions.
Okay.
So how, the first one, so what I think I'm hearing you say is your unit, your mobile unit, which I think is a brilliant idea. You're triaging or doing wellness checks?
It's actually a true, fully functional primary care clinic. So we are doing preventive care visits, which I recognize that there's not really good evidence that an annual visit necessarily is good health outcomes in the long run. It doesn't necessarily save cost. But for our particular population who is just foregoing care altogether, it allows us to at least develop that initial relationship, uncover the needs, and take care of those. So we're doing that, and then we're also doing chronic care follow-up.
So you're engaging patients who may never get care.
Exactly. What we found actually with our workplace screenings is that a lot of people use the screening as their doctor's visit for the year, even though they don't have any treatment, limited counseling. They consider that their touch to healthcare for the year.
So you're not the primary care physician, is my first question. And the second one is, how do you access or connect to their infamous EMR records and get the information that you obtain into their overall system?
I'm glad you brought that up. We, as a system, we have an enterprise record, and through AT&T Wireless, I connect through our Citrix portal, and on the bus, in a conference room at an employer, I have access to our enterprise record. So I'm documenting, in our case, NextGen, and we have Epic on the inpatient side within our system.
Thank you.
Uh-huh.
I'm very curious. I've been thinking about this morning through some side conversations and listening to Dr. Buckman about the role of health plans versus the role of providers, particularly around population health. And obviously, these two markets are so different and have resulted in differences. I wonder, have any of the self-insured employers that you're working with said, "Would you like to be our insurer?"
We-
The talk of disintermediation was really big in the 90s.
Right.
When this was happening, or do you see that, in that perfect world, population health management is a provider function, and an insurer, maybe not Blue Cross Blue Shield of Alabama, does other things well?
Right.
Do these coexist?
That's a good question. Certainly with our direct-to-employer approach, we're trying to prepare ourselves for whatever is coming in the future. We had a health plan in the past and did not have a good experience. So I will tell you that our CEO would say we don't want to take any risk, but we do want to be seen as a partner. And in fact, I've done a lot of talking with HR directors and benefits managers about how to decrease barriers within their own health plans. So a lot of times their health plan brokers that they are engaged with aren't as aware of the problems that exist with the structure of their plans as I am as a primary care provider, as was mentioned in an earlier discussion. So we want to be seen as a partner because, yes, eventually it is likely we will move towards at least a narrow network type of plan, and certainly we want to be involved in that, but probably not full risk or risk sharing. All right. Yes, sir.
They frequently talk about healthcare being responsible for 10% of your health, and the other social determinants comprising 90% of your health. It seems like in Alabama, the social determinants, education, lifestyle, are not doing so well. Then the healthcare is negative. Do you have data that shows that the outcomes in Alabama, how they compare infant mortality?
I don't have those right now, but certainly that is readily available, and it's not good, as you can imagine. What we would like to be able to show is that our type of intervention does result in improved outcomes, and we're just too early at this point to be able to do that. Our organization actually, this is interesting to me, we applied for one of the Practice Transformation Network awards that the CMMI put out, which still haven't been announced yet. We haven't been told no, which is good. But we had a conversation with several individuals from CMS about that particular opportunity, and one thing that was repeatedly brought up by CMS was, show us the data. Show us that, if we improve by this amount, then we can have this return on investment that we can show to Congress, in essence. We're not there yet. We are still in the baby stages of just getting all of our computer networks linked, and the data that we do have, I mean, it's ridiculous. We can't really evaluate hemoglobin A1Cs across the population because one EHR brings it in as hemoglobin A1C and another brings it in as HbA1c, and they just don't talk to each other. So that's our reality right now, and we're doing the best we can with it.
I also want to commend you on staying in Alabama.
Thank you. Yes. That came up frequently during my trips to Boston. Everybody was like, really? Thank you.